And now it's my pleasure to introduce another incredible public health champion, our keynote presentation. This is Dr. Lauren Smith. Lauren Smith is the Chief Health Equity and Strategy Officer for the CDC Foundation, and she's a member of their executive team. You can read more about her in her bio that's in the program materials, but I want to let you know that Lauren really is a true public health and health equity champion. I know this, having worked with her for a number of years at the Massachusetts Department of Public Health, where she was both the medical director and the interim commissioner. She's also somebody who still makes her home here in Massachusetts, and so we are really, really lucky to benefit from her work. Thanks, Lauren. Thank you so much for being here. And now I turn it over to you.
Well, thank you so much, Carlene, for that warm introduction. And I just have to say, Senator-elect Liz Miranda is a very hard act to follow. Even pre-recorded, she's a hard act to follow because she's so impressive and compelling. So kudos to her. And just want to start by thanking you, Carlene, and your team at MPHA for inviting me to participate in what has so far been just tremendous conversation. It's so energizing to be among friends and colleagues, many of whom I haven't seen for a while. So I appreciate that, even though it's a virtual convening. Although given the rates of circulation of all three viruses now, I think that's probably okay. But I did want to start by taking a moment to give the MPHA team the kudos that you deserve for developing that health equity policy framework that Omi described and went through. I just can't say enough of how thorough and comprehensive and thoughtful it is. I am so impressed by how it really moves beyond an individual focus and really is squarely focused on the structural and systemic sort of approach, as opposed to sort of being reduced to, at the individual level. I'm also struck that the explicitly talking about leading with race, but not exclusively with race. I think your explanation of why you're doing that and the rationale behind it and the data behind that really should be required reading for anyone who's engaged in this work and is confronted with those questions. Well, but why is racism more important than other isms, or might we want to focus on that differently? And then lastly, I want to say that I'm so grateful that you are able to be both bold and clear-eyed about the historic and current challenges that we are facing, while also being hopeful and aspirational about the future. 50 years ago, our country was able to escape the literal bounds or bonds of gravity to be able to land people on the moon. So surely 50 years on, we can escape the binding or the bounds of structural racism and other biases that are holding us back from really achieving our true and full potential in ways that Senator-elect Liz Miranda was just talking about. So thank you for the opportunity to connect with you this morning. And I really welcome the ability to share with you a document, some thinking that we have been doing at the CDC Foundation about how we can use public health data to drive equity. And as I think about the health policy or the health equity policy framework that you all developed, you have the I think 5 different sort of sections or components of it, the definitions, the framing, the policy development, the community partnerships, and the organizational leadership and culture. And all of those are like super important. I was thinking that maybe the work that I'm about to sort of share with you could be a section 6, which is sort of, how can one approach using data to support and to champion and further the goals and objectives that you so compellingly lay out in the framework. So that's the mindset that I hope folks will have as we go through here. So at the foundation, which is a nonprofit independent organization that was founded or created to support the overall focus of public health generally and the CDC more specifically. We have been thinking about, just the rationale for the creation of more equitable data systems. As you all know, as public health practitioners, we want folks to understand and think about data when making decisions. And we know that data affects the policies and the laws and the regulations, all the things that Omi and Craig were talking about. And if data are in fact the building blocks of how we can understand and make sense of, and then ultimately eliminate health disparities, we need equitable data systems to be able to do that. And so we're thinking about the intersecting sort of ideas of intersectionality, which you also, I think, importantly describe in the introductory sections of your framework, with data democratization, with the concepts of systems level change as opposed to solely individual or programmatic level change. And then, linked into all of that is health equity. So we're thinking that equitable data systems need to have all of these different components. As we went about this work, we recognized and want to fully acknowledge at the outset that there is a robust and healthy and growing field that is focused on data equity. And so what we sort of have synthesized or sort of compiled, we're hoping can be seen as a complementary resource to the work that is currently being done and has been done in the field, all the way from the Actionable Intelligence for Social Policy and their toolkit for centering racial equity. RWJ, as an example, created a document and charting the course for equity centered data systems. And of course, the Urban Institute, has done work, and, many others that you'll see listed in our document, because we really did want to acknowledge the work of others that we were seeing and attempting to sort of synthesize, and what we hope will be a helpful way. We wanted first sort of level set around what we mean when we talk about the data lifecycle, and the fact that there are data goes through all sorts of different stages, starting with the planning stage, really, which is an essential component where you need to develop the purpose, you need to define the issues that you're going to address. And I think Craig, talked about this. Who gets to decide that? How are those priorities set? It's essential in the planning that you understand the historic and current context, both generally, but also locally in the particular community or neighborhood that is of interest. And then thinking about what kinds of inclusive methodologies you're going to employ to ensure that you are tapping into the experiences of and the perspectives of the folks that I think, as Omi mentioned, are maybe closest to the pain, but not included in developing the responses or the ways of making change. So then there's data collection, which is, kind of straightforward. It's about sort of the gathering the information, including, both primary and secondary data collection. Although this may seem straightforward, sort of how you go about doing that, who's included, how do you ask the questions, how do you frame the questions? All those things are super relevant in this part of the life cycle. Access, is something that sometimes isn't sort of included in the life cycle, but you feel like it's super important because that really is focused on who can obtain, view, use, be able to really dig into the data, to wrestle with it, to see if it represents their experiences, to see what can come out of it. In terms of analysis, again, using data to develop actionable and informed conclusions is what we hope. That's the goal for excellent analysis. But being able to do that requires that you understand going into it what your potential biases might be, and some of the, again, with the legacy of historic or ways of thinking or ways of understanding problems could lead you to potentially not really fully understand or be able to do analyses that are applicable or that resonate with the communities of interest. And then finally, dissemination, where you're thinking about how are you going to share the findings with appropriate audiences to influence all the things that I think you lay out in the policy framework that you want to influence. And a key part here, I think, is to intentionally go against the pattern of often having data be an extractive process, where we, the royal we, academics and government or public health agencies, even with the best of intentions, may go into communities and ask questions, collect data, and then never come back to help make sense of it, to share what was found, to give back the data to those folks who were gracious enough to give their time and experiences in ways that would be helpful to them. So thinking carefully about that dissemination is another important piece. So our focus in this document, which we can put in the chat for you so that you can get it, it's on our webpage, is really applying equitable practices throughout every stage of that data lifecycle that we just sort of went quickly over, and integrating them, at each point. So we're situating the data lifecycle within this orbit or within this sphere of these other principles, and not that only one principle applies to one part of the data lifecycle. So what I want to do next is just take a moment to go through the 5 principles, which will be, I think, very recognizable to you. And I'm sure many of you are already applying and doing this in your work. And then I want to think through a little bit about what does it look like to do this, and what does it look like when it's not happening? So so the first principle to talk about really is this around recognizing and defining the systemic, social, and economic factors that affect both individual health outcomes as well as community level and population health outcomes. So that is exactly what Craig and Omi and what Senator-elect Miranda were talking about. What are these factors, and how do we not just account for them, but how do we include an understanding of them in our pursuit and analysis of data? So some questions for us to think about as we imagine how would we go about, applying this principle is, what policies, customs, and sort of frankly biases that might be unseen may systematically, cause groups to have worse health outcomes, and how do we take that into account? How do we build that into our understanding of the data? The second principle is this idea of using equity-mindedness as a guide for language and action in that continued process of both learning as well as disaggregating data, and really questioning assumptions about what is relevant and what counts as being effective. I think Omi made a great point when she was talking about the first section of your document, where you really dig into some of these ideas around language and definitions and what do people mean. And it may seem, I don't know, like pandering to the quote politically correct, but rather I think of it as being intentional and thoughtful, recognizing that language has power, and that we will do well to to interrogate and think through what are we actually meaning, and by what we, in terms of, what language we're using, just as an example. In terms of, some thought questions there for this principle, I think a key one, and I think it's resonates again with how you all have been thinking about your work, is how does using racial and ethnic groups as a proxy for genetic or biologic difference obscure the role of social systems in producing different health outcomes? So if you take the issue of maternal health or maternal birth outcomes that Senator-elect Miranda and Omi were talking about, those of you who are steeped in that literature or are familiar with it know that many of the reports and work will look at the poor outcomes for the worst outcomes for Black women, and they'll control for education or income or work status, et cetera. And then a lot of times they'll say, well, we controlled for those things. There was still this difference for Black women. So there must be something biologically or often genetically related to Black women that leads to these untoward outcomes. And of course, we know that that's a fallacious sort of approach. It's a fallacy, but people are still doing it even in the medical and the public health literature. So, we need to continue to make the case that it's the experience of race and racism that has the biologic impact on Black women's health outcomes, rather than a purported, genetic or DNA kind of issue that, then, can't be dealt with, and you don't have to take responsibility for it. What about our data collection tools and the way we frame things as being primarily focused on deficits and challenges as opposed to assets and benefits? And I think this is one we come up against a fair amount in public health, where again, not intentionally, and we're not meaning to do harm, but we, we'll say, oh, well, this community is facing these challenges or having these problems, without also thinking about, well, what are the sources of resilience and strength in those communities that can be called upon to combat some of those challenges. And so I think thinking about those assets and strengths is essential, and we have to think about how are we doing that within our data systems. So the third principle we want to highlight is around, and again, this seems like this is right up your alley, proactively including participants from the community of interest in all aspects of the research and program design. And the idea there is really, you want it to be relevant for that particular community. And even as one needs to use standard data collection and analysis sort of approaches so that conclusions can be compared, or sort of analyses can be compared across time and across place. So in this section, we think about what or how disseminations of the different conclusions that are drawn are most important, and what are the audiences rather that are most important to reach, and what about the stories that the communities feel like need to be told from those conclusions, and what is most meaningful to them in terms of telling those stories. Next, we have this idea about collaborating between or among agencies and the community to generate a shared agenda that includes both the plan for, how we're going to deal with data completeness. We saw, as an example, in the pandemic, there was a big issue on not being able to sort of report on hospitalizations, deaths, and then ultimately like vaccinations by race, ethnicity, because there was a fair amount of missing data. So what do we need to do to get data complete on that? And I think if we have time, we can talk more about that, because we found some very effective ways of doing it, but one just has to put that energy into it. And here, some questions for us to think about would be, how are the community perspectives going to be incorporated throughout all stages of the project, and how are they going to be included in thinking about what the solutions to the data issues, are, because people, and the community will have some good ideas about how to deal with that. And then lastly, facilitating data sovereignty by ensuring that there's a way for communities to be considered in how they govern the data, how it's disseminated, and what happens with the data that, comes out of or is developed from their communities. And, that goes back to power, which I know you all are addressing in terms of the power building aspect of things. Who has the ultimate decision making? And if the community raises concerns, will the ideas be revised or reconceived or even suspended until clarity and consensus can be obtained? So as we think about applying those principles across the data lifecycle, we wanted to sort of illustrate how they could be applicable, at each stage. So in the planning stage, thinking about data and community engagement to prioritize what issues are addressed, what are the questions that need to be asked in order to address those issues. And that's really, all about addressing the research agenda and a plan. So at the collection stage, what are the public forums that are being developed to demonstrate how public health data collection can actually contribute to community health and to differentiate how the approach that includes community can feel and be experienced as opposed to the more extractive or unilateral kinds of experiences that communities may have had in the past. In terms of access, developing, a process so that with policies, clear policies and procedures that are understandable so that, communities and other folks can make requests for the data. Analysis involving the diverse constituencies in the early conversations to be really thinking about the algorithms and statistical methods. For example, many of you are aware that when race ethnicity data is absent, there's an imputation process that can be undertaken that looks at geography and surname. And one of the things that, to keep in mind is the only reason that imputation approach works is because we have been so heavily residentially segregated that, the last name Smith means something different in Roxbury than it does in Newton. So just to be aware of, if you're using that, like to know why it works, and is that something that you want to be thinking about. And then lastly, in terms of dissemination, using a strength-based approach when discussing populations. I'll never forget talking to some members of the community said, do not come in here and tell us again what's wrong with us, right? So in using not only strength-based, but that systems level approach, so focusing on what is holding these problems in place beyond the individual level so that the attention can really be focused there, so that we can avoid the sort of sometimes in unintentional or subtle kind of judging and blaming and marginalizing of communities. There's also an opportunity to think about this work at different organizational levels, from national to state to local. And so here are some ideas at the state and local level, which seem most relevant for us here, but it, just keep it in mind that there's, different, it's often overlapping, but some different opportunities, say for tribal and indigenous groups or groups in the territories to be thinking about this. And again, sort of, at the planning stage, thinking about using community engagement to prioritize all of these different things that we just went through are examples of what can happen at the state and local level. However, we recognize that achieving equitable data systems is not easy, or else we would have done it before. And we recognize that there's many challenges that we face in order to do that. So one, without a doubt, is resource constraints. Where do we find resources to support the application of the principles? And when funding is limited, or if funding is limited, as it usually is, does that mean we have to choose one community to partner with over another? I think the resource constraints, we do have a little bit of wiggle room now, because as many of you know, there was a substantial amount of federal funds that went to the states around their equity work. And then just last week, or perhaps the week before, the CDC announced $3.5 billion going out to the states for workforce, public health workforce investment. Now, of course, the details matter in terms of how those funds are getting dispersed and what kind of partnerships are being developed with community, et cetera. But there, for the first time in a long time, of a long period of disinvestment and underinvestment, there are resources flowing to states. So working collaboratively with state public health agencies about how they're going to approach that, now is the time to do that. Integrating communities. So how do we think about this balance of individual communities managing the data versus, or maybe not versus, but also what does it mean to be part of a larger data system at the state or national level where resources can be consolidated? So there is some, balance there around local control and sort of state or national economies of scale. What about this idea that we talk about tailoring, recognizing that there's different communities which have different challenges. And so if we want communities to have community specific or relevant data standards and definitions, how are we going to then compare outcomes across communities and over time? So this is a very important challenge, again, one that is surmountable, but naturally one that comes up. And then lastly, what about data democratization? How do you balance promoting sort of open source, accessible data, while at the same time protecting the privacy of the communities and the individuals who live in those communities where the data is being gathered? So thinking carefully about that balance between privacy and access and openness, I think is a really important conversation that we need to be having. I'm hoping that there's multiple ways that we can continue this conversation, including sharing the principles with your colleagues and partners, especially your community partners, or those of you who are community-based organizations, thinking about how these are playing into your work, engaging in dialogue about how the principles could be applied to your work, how they're already being applied, what challenges you faced in doing this already. And then we'd be thrilled to have you connect with us at the CDC Foundation. We'd love to hear your insights and your stories. Again, sort of how is this working for you? What kind of support or resources do you think would be helpful to you in incorporating these principles into the work? How are you identifying and overcoming the challenges to applying these principles to your work? And here's our webpage. So if you go to the CDC Foundation webpage and look for under health equity, that's where our webpage is, and describes a little bit more about our work and what we're up to, and has a link to this document. And so I just want to leave you with this quote, which I love, from James Baldwin, that not everything that is faced can be changed, but nothing can be changed until it is faced. So it feels like we are at that moment, deeply in that crucible moment where we are experiencing trial, like a significant trial. So we get to decide how do we want to come out of that trial? What do we want to be after we've gone through this crucible moment? So thank you.
Lauren, thank you so much. I have taken a bunch of notes, and we don't have tons of time for questions, but I want to ask a couple of them, if that's okay. So I so appreciated your the point that you made about race and racism, that health impacts are really the result of racism, not of race. And it is, I just think that's such a critical insight. And it certainly aligns with what we know about where most of our health is created, right? Most of our health isn't created by our genes or our biology or even our clinical care. It's created in the social conditions in which we live. And racism is one of those. And so I think that points us towards also needing to use language really carefully around that, right? We often say race, like leading with race, when what we mean is leading with racism, that we need to think about leading with racism. And I just wonder if you all at the CDC Foundation have been thinking about that language distinction. This talk made it, I've thought about that before, but this talk just made that so crystal clear to me.
Well, yes, we're definitely thinking about that because it has been a thorn in my side for my entire career when people would conflate the two. And, I don't think this audience needs to know that, race is a social construct that we have developed to kind of sort people into different categories. And it's not real, genetically, we're far more the same than we are different. And, what it's mean to be white or non-white has changed so dramatically over the last 100 years in terms of who's in and who's out, that it's laughable that we would even kind of try to assign scientific validity to it because it's, so amorphous. That said, you could just pick up any public health or medical journal and still see that without the nuance of what we're using this for is as a proxy for the experience of racism. Subtle, structural, all the different levels, et cetera. So
I feel like that's a huge take home for me in your presentation.
For people who want to go into that more, Carlene, I would recommend there's a really great piece in Health Affairs that talks, that calls journals and, academics to task around using race in that way or misusing race in that way. And I would call people's attention to that. We refer to it.
Great. We'll find that and send that link out after the conference is over. We're going to be sending some materials to folks, and we can include a link to that article or a PDF if we need to PDF it.
Yeah.
That's great. So I do have a question though, and I know we're very close to time, but you talked, really so many of these principles assume building community input in from the beginning.
Yes, sure.
I think the challenge for many data collection, whether it's the state, private universities, whoever is doing that data collection and analysis, is there hasn't been the necessary work to build the trusting partnerships with community residents to get that input in a way that has integrity.
Yeah. Well, that's what I was alluding to, some of that extractive, that principle, recognizing the historic context, like what's come before. You're not the first, we, the royal we, are not going to be the first people that have set foot in communities to say, hey, we'd like to talk to you and get some data, right? So we know that things have come before and that have often left some not great tastes in people's mouths. And so recognizing that and coming in with that humility about like, well, how is this going to be different and how are we going to show up differently? And I think you talked about this, Carlene, in one of your earlier comments today about being trustworthy, and not sort of demanding trust, but being trustworthy. So, and part of that is that reckoning piece and acknowledging the missteps and what's happened before and not trying to gloss over it. You have to reckon before you can get to repair, before you can get to, change. So.
Yeah, I love your language of humility, the idea that so to build that trust, we probably have to be way more humble than we have been before, because we don't, Craig talked about how much and I presume that he was referring to the royal we of public health, have denied our history. And it feels like some of that is also what we have to overcome in this work around data, around something as, ordinarily, like thought of ordinarily is so straightforward. You get in there, you collect the right data. If you collect the right data and look at it the right way, you're going to get the answers you need. And every single one of those steps is fraught with the history that has created the challenges for collect the data the right way, ask the right questions, do the right analysis, and get it to the right people. Like each one of those steps has a history that makes it hard.
Yeah, totally. And I mean, just two things. One is there's a lot of, conversations like, well, this is, the historic issues around the public health study that was at, Tuskegee, or, the egregious sort of experience of, Henrietta Lacks, et cetera. So like when people are, it's like, yes, and people don't have to go back that far, right? They can go back to like this morning or yesterday, or, when they experience something not great in a health setting or even a public health setting or what have you. And so I think that idea of, yes, we have to totally acknowledge the historic stuff, but we have to also continue to sort of confront the current contemporary experiences that people are having that are also reinforcing that lack of trust. So I feel like that's important to not lose sight of.
Yeah. And again, I'm going to go back to a phrase that you use, like looking at the systems that are holding these problems in place is critical to our being able to understand what the issues are, because it's not about the individual. There are systems and structures that are holding this stuff in place to create these inequities.
And I think, the incredible work by Isabel Wilkerson, in Caste, I don't know if people haven't read that book, but if not, I would put it on your, holiday list to give and to receive. And I'm not getting any royalties or anything. I feel like I want to recognize it. She does a great job in that book talking about moving from the individual focus on an individual as having, racist ideas. And we do that in the media, we do that,
Right.
And that's such it's understandable, but, she's saying it's like a strategic error, because then you're looking in a direction that's going to focus on weeding out, the individuals, as opposed to the broader underpinnings of what creates the environments where all of us have assumptions and implicit biases and things. So it's great read if you haven't yet gotten to it.
Thank you for that. And Lauren, thank you. I know everybody out there is clapping to themselves, as I am. Thank you for that great presentation and the such questions for reflection, like those questions for reflection. I really am going to reflect on those. Thank you so much.